Hello and welcome to the topic Osteomyelitis in the module Rheumatology. By the end of this topic, you should be able to define osteomyelitis, discuss the epidemiology of osteomyelitis, outline the pathophysiology and causes of osteomyelitis, outline the classification of osteomyelitis, describe the clinical manifestations of osteomyelitis, outline the investigations that are carried out for osteomyelitis, and finally discuss the principles of management and the complications. Let's get started. Osteomyelitis is defined as an inflammatory condition of the bone caused by an infecting organism. The incidence of osteomyelitis, specifically for peripheral bone infection, is about 2% a year. There is a male predominance in this disease, and 20% of all overall cases are hematogenous spread. There are some associated factors that contribute to the development of osteomyelitis, such as increasing age, immunocompromised conditions, previous osteomyelitis, penetrating injuries, recent surgery, distant or local infection, sickle cell anemia, rheumatoid arthritis, and chronic kidney disease. In normal, healthy individuals who have normal bone, it is unlikely for them to develop osteomyelitis as the normal bone, which is intact and healthy, is highly resistant to infection. However, in some circumstances, such as inoculation of organisms, presence of bone damage, and/or presence of hardware or other foreign material, individuals might have higher chances of developing osteomyelitis. The factors that are needed to be considered for the development of osteomyelitis would be the virulence of the infecting organisms, the host immune status, and bone vascularity. When bacteria enters the bloodstream, they express adhesins and bind to protein in host tissues. Polysaccharides, extracellular matrix is produced and eventually forming biofilms. Sufficient organisms present in the biofilm undergo quorum sensing, causing further development of mature biofilm. This eventually will cause separation of fragment of the biofilm and subsequently the spread of infection. The organisms in the biofilm enter dormant state and the glycocalyx protects the organism from host immune system. The most common organism for osteomyelitis is Staphylococcus aureus, and it has a number of virulence factors such as having the ability to invade living cells and survive inside osteoblasts. Now we are going to look at the causes of osteomyelitis. A trivial skin infection may cause bacteremia, or it may result from more serious infections such as acute or subacute bacterial endocarditis. Intravenous drug misuse has been linked to hematogenous osteomyelitis involving the long bones of the vertebrae. In the developed world, bone infection in adults is now mostly seen after surgery or injury, and this is caused by contiguous focus osteomyelitis, and usually they are implant related. Other causes would be immunocompromised patients and patients with multiple comorbidities. The MEDIT classification classifies osteomyelitis physiologically and anatomically. There are three physiological classes of patients A, B, and C. A being people with no comorbidities that compromise the outcome, able to withstand surgery and antibiotic therapy. B are those with comorbidities that directly reduce the likelihood of wound healing, reduce the efficacy of drug treatment, or increase the risk of surgery. And C are people who are severely compromised, that treatment has an unacceptable risk-benefit ratio, and therefore the treatment of the infection can be more harmful than the condition itself. For the anatomical types, there are 4 types, which is 1 to 4, based on the degree of bone involvement. 1 being medullary and endosteal bone, mostly associated with hematogenous infection. 2 being superficial osteomyelitis from contiguous focus infection, often arising in the base of the varicose ulcer or from external trauma or a pressure sore. 3 is both medullary and cortical involvement, and the osteomyelitis is limited to the part of the circumference of the bone, leaving a healthy portion of the bone to maintain stability. And finally, 4, where there's diffuse involvement of the entire circumference of the bone. Besides that, we can also classify osteomyelitis based on the type of spread, which are hematogenous and non-hematogenous osteomyelitis. For hematogenous, it is resulted from bacteremia, usually monomicrobial, long bone involvement is the most common in children. Vertebral involvement is the most common form in adults. Risk factors include sickle cell anemia, IV drug usage, immunocompromised state, and infective endocarditis. For non-hematogenous osteomyelitis, it results from contiguous spread of infection from the adjacent soft tissues to the bone or from direct injury or trauma to the bone. Usually, this is polymicrobial. It is the most common form of osteomyelitis in adults, and the risk factors are diabetic foot ulcers or pressure sores and peripheral arterial disease. The symptoms for osteomyelitis would be fever, bone pain, redness and swelling, limited movement, fatigue, limb deformities, reluctant to weight bear in children. And these are particularly symptoms of acute osteomyelitis. Whereas in chronic osteomyelitis, it is often described as having non-specific pain, low-grade fever, malaise, persistent discharge from a wound, hot inflamed foot in diabetic patients, as well as foot ulcers. During physical examination, the signs that would be usually elicited would be presence of local inflammation, which is the evidence of erythema, tenderness and swelling, areas of point tenderness, decreased range of movement above and below the affected area. Decreased range of motion is usually due to pain or septic arthritis. Torticollis and low back pain may indicate axial osteomyelitis or lumbar discitis. Other signs that are suggestive of vertebral osteomyelitis would be paravertebral muscle tenderness and spasm and limitation of spine movement. In chronic osteomyelitis, there are a few signs which are crucial to look out for, such as angular deformity or shortening of the limb that may have resulted from premature fusion of the physial plate, acute or old healed sinuses, fracture fixation, evidence of previous operations, including scars and previous flap designs, tenderness to percussion over the subcutaneous border of the affected bones. As osteomyelitis is a systemic disease, it is very crucial to look out for signs of complications such as sepsis or septic shock, spinal cord or nerve root compression and meningitis, and presence of neurological signs specifically in the cervical or thoracic involvement. As for investigations for osteomyelitis, we would first talk about the diagnostic tests. Imaging such as plain X-rays at the site of the infection would be useful. In acute osteomyelitis, the features can be observed would be osteopenia, bone destruction, cortical breaches, and periosteal reaction. Whereas in chronic osteomyelitis, features such as involucra, sequestrium, cloaca can be seen, as shown in the diagram here. In vertebral osteomyelitis, rarefaction of the single vertebral body, anterior bone destruction are observed. In discitis, there will be decreased intervertebral space and erosion of the vertebral plate. Bone MRI is also an imaging modality of choice with a sensitivity of 90 to 100%. High signal on T2 images of fat suppression sequences and vertebral bone changes are among the changes that we would see on a bone MRI. Next would be bone sampling and blood culture, which would show positive for culture. Usually 2 cells of blood culture before antibiotics treatment to detect the causative organisms are taken. Inflammatory markers such as erythrocyte sedimentation rate and C-reactive protein would be raised. Raised white cell counts can also be detected in full blood count. To monitor the efficacy of treatment, usually a C-reactive protein can be used as it will usually normalize rapidly after successful treatment. As there are other bone diseases that might manifest similar symptoms such as osteomyelitis, a bone biopsy would be helpful for physicians who are suspecting other pathologies to detect other conditions such as presence of tumor or granulomatous disease. For secondary prevention tests, blood investigations such as HbA1c or fasting blood glucose would be helpful to assess the control of diabetes mellitus as patients with uncontrolled comorbidities have increased risk of developing osteomyelitis. Now, we are going to talk about the principles of management. First, we would talk about how we would relieve the symptoms. As patients might present with complications such as sepsis or septic shock, it is important for the physician to activate the 1-hour septic bundle protocol as soon as sepsis is detected. For patients who are experiencing pain, analgesia such as non-steroidal anti-inflammatory drugs and opioids can be given to relieve pain. The treatment is depending on the type of osteomyelitis and the location of osteomyelitis. The treatment given for patients will depend on the type and the location of osteomyelitis. For peripheral osteomyelitis, flucloxacillin is usually given for 6 weeks, and patients with penicillin allergy, clindamycin would be a preferred choice of treatment. Tazocin is considered if Pseudomonas infection is suspected. In patients who are experiencing deterioration of the limb or having imaging that is suggestive of progressive bone destruction, surgery would be recommended. For vertebral osteomyelitis, the preferred antibiotics would be vancomycin and third or fourth generation of cephalosporins such as ceftriaxone for 6 weeks. If the first-line treatment is contraindicated, patients can be given daptomycin and fluoroquinolones such as ciprofloxacin. Surgery is usually considered if there's progressive neurological deficits, progressive deformity, and spinal instability with or without pain. In chronic osteomyelitis, the treating physician will prescribe long-term antibiotic suppression and usually surgery is required. After surgery, a short course of antibiotics, which is usually 2 to 6 weeks, is prescribed. As we have mentioned that one of the causes of osteomyelitis is presence of comorbidities, so it is crucial to refer all diabetic patients for diabetic foot care and emphasize on optimum diabetic control as secondary prevention of osteomyelitis. Practicing good hygiene, avoidance of smoking, and IV drug use are also important to prevent the recurrence of infection. Patients need to be educated on the signs and symptoms of recurrent infection so that they can seek treatment earlier if needed. There are short-term and long-term complications of osteomyelitis. The short-term complications would be drug reactions, flap failure, fractures, neurological impairment secondary to abscess or bony collapse, and intravascular catheter-related infections. Long-term complications would be requiring amputation, growth disturbances in children, joint stiffness, and recurrence of infection. So in summary, osteomyelitis is defined as an infection of the bone. Staphylococcus aureus is by far the most common causative organism, except in patients with sickle cell anemia where Salmonella species predominates. Osteomyelitis can be divided into hematogenous and non-hematogenous types. Patients usually present with fever, pain, with the clinical signs of tenderness around the bone area with limited range of motion. The preferred investigation to diagnose osteomyelitis would be MRI and plain X-ray. The principle of management would include prescribing antibiotics and surgery in some circumstances. The complications would include the complications of treatment, complication in a growing child, as well as the complication of the progression of the disease. We have come to the end of this topic. Thank you.